Okay, so we're focusing on this work on stage 3 bladder cancer, and the regular treatment for these group of patients is radical cystectomy. And we also treat these patients, if possible, with cisplatin-based chemotherapy. Overall, the survival for these group of patients is quite poor. And by giving neoadjuvant chemotherapy, the prognosis is somewhat better, but that's still modest. And a large number of patients is actually ineligible to receive cisplatin-based chemotherapy. And for this group of patients, there's actually no good alternative, and they just get a straight radical cystectomy instead. So for this group of patients, we devised the NABUCCO study a few years back. And in this trial, patients were treated with ipilimumab and nivolumab preoperatively, followed then by the radical cystectomy. And we noticed in this first cohort that we did that there was a pathological complete response rate of around 46%. So that was really, really good. And we tried to further increase this and to make the tolerability for the treatment a bit better by just adjusting the scheme a bit. And for that reason, we also started the second cohort of this study. One thing that we noticed in the first cohort of NABUCCO was that the exposure to nivolumab especially was quite low, because we only give it at 1 milligram per kilogram during the second cycle, and then at 3 milligrams per kilogram at the third cycle. But that's already overlapping with the surgery window, so the exposure in the end to nivolumab was quite low. So for the second cohort, for one of the two arms, we also added nivolumab to the first cycle of therapy. And then for the other arm, because we're having two arms in this follow-up study, we switched doses. So instead of ipilimumab 3 milligrams per kilogram and nivo 1 milligram per kilogram, we reversed that. So we have IP1 and nivo 3 instead. And then still the third cycle is still the same. So they get an additional cycle of nivolumab 3 milligrams per kilogram. So in this group of patients, we looked mainly at, as this was our primary outcome, at a complete pathological response rate. So we want to compare that for the two arms. And we also looked at toxicity. And what we found actually was a bit of in contrast to what we expected, because what has been seen and found in melanoma and also in other cancers was that EP1 milligram per kilogram, as opposed to 3 milligram, is just as effective and has less adverse events. But what we found is actually that the response rate for this dose, so with EP1 versus EP3, was worse as opposed to EP3. So for, as I mentioned, in the first cohort with EP3, we already found a pathological complete response rate of about 46%. And then for the cohort with EP3 in the second cohort, we found a very similar complete response rate of 43%. So it's very similar. But then for EP1, we only found a 7% complete response rate. So it was a pretty remarkable difference in this dosing schedule and the outcomes for these two regimens. Our study was not powered to really pick up differences in adverse events, but we found one third of the patients for EP3 grade 3/4 immune-related adverse events, and we found 20% of patients in the second cohort, so it's EP1, that had grade 3/4 immune-related adverse events. In melanoma, this has also been tested in a very similar way. So EP1 was compared versus EP3, and there it was found that the efficacy was very similar. And then for a lot of other tumor types, it was assumed that EP1 would also be sufficient. And a lot of studies have been going on with EP1 for instance, head and neck cancer and also colorectal cancer. But we would, based on our data in bladder cancer, where we found that indeed EP1 might not be just enough to help these patients. We think it's worthwhile to also test this in other cancer types, so to see if maybe EP3 or another dosing schedule would be worthwhile as opposed to just trying with EP1. And I think for the bladder cancer field specifically, I think this is a really good alternative for chemotherapy that has been used now, and especially for patients that are ineligible for cisplatin-based chemotherapy. And of course, it would be very interesting to test chemotherapy and immunotherapy side by side in the same group of patients to see if this is actually just as effective or even potentially maybe even more effective than cisplatin-based chemotherapy as a preoperative treatment for stage 3 bladder cancer. So the first thing that we wanted to investigate is to see what is the actual biological mechanism and rationale for the difference in EP3 and EP1, specifically in bladder cancer versus other tumor types. So we're currently in the lab also investigating this to see if we can unravel this mechanism. And we have multiple different other studies that are ongoing. And of course, one of the things, as I just mentioned, it would be interesting to test in the cisplatin-based eligible population to see cisplatin versus EP plus nivo. But this is not planned yet, so we'll have to see what comes next.